Thanks for coming along. I'm here to talk to you about overcoming barriers to technology adoption in healthcare. And I'm going to do that by talking through my personal experience in the workforce and also our experience at Surgical Partners of overcoming these adoption barriers in healthcare with our clients and the clients we're still working on. So hopefully some of those insights will be relevant not only for those of you in healthcare, but for those of you trying to drive adoption in other industries. So a little bit more on who I am. So the perspective that I'm bringing to this topic. I actually come from a healthcare family. My father's a radiologist, my mother's an ICU nurse. But I actually came back to healthcare sort of in a roundabout way. My undergraduate training was as a chemical engineer. And then, like many engineers at the time, this was in the late 90s, I didn't actually go into engineering. One of the reasons there's a big shortage of engineers at the moment. But like many engineers at the time, I went into banking. I was a faceless money man. And I did that for about 7 years, and I learned a hell of a lot. Like, I worked with very intelligent people at Macquarie Bank for 7 years and learned a lot from them, learned a lot about the financial markets, financial literacy. And I was a healthcare analyst, so I analysed the leading healthcare companies and got a very good understanding of the healthcare industry from the top down. So very good experience, but after 7 years, I kind of wondered where my soul disappeared to a little bit. So I wanted to get out of banking, and eventually, after a few travails, I eventually became a technologist, an entrepreneur. So that's been my journey, and that's the perspective that I'm going to be bringing to this subject. So why is technology adoption so important in healthcare? So to give you some perspective on this, as a share of the economy, it's gone from 8.8% 10 years ago to 10.3% of GDP. Just growing as a share of national wallet. And obviously, that can't keep happening. I mean, at some point, you can't have more than 100% of a wallet. And, while healthcare is very important to us all, I'm sure, it's something that's pretty unsustainable. And the reality from this chart is the vast majority of that, and most of the growth in it actually, is from government. So this is state governments funding hospitals, it's the federal government funding Medicare. And that's our money. This is all of us, well, I assume most of us are paying tax. This is our money. And in many cases, it's our money going down the tubes. So it's a very important industry to attack from an efficiency standpoint, and inevitably, efficiency involves workforce success. And the government knows all this, of course. I mean, they've run all kinds of reports. This is from a Productivity Commission review in 2017. So health and education are under direct control of governments. So delivering them more efficiently, including the better outcomes for the users, will deliver more benefits even than traditional industry reform. To give that some more context, think about contributions to employment growth by industry. So this is the government's projections, Department of Employment Skills, Small and Family Business it's now called, putting out these employment projections around contribution to employment growth. This is health here. It's more than double the nearest, and 10 times most. So significantly more growth in the workforce than any other industry. And not only is that a projected trend, it's going off the last 15 years. So if you look again at all the same industries, health and social assistance over the last 15 years, almost double. And what I think is really interesting about this chart is it's broken down into types of work. The vast majority of health is non-routine. So non-routine manual, non-routine cognitive work. What does non-routine mean? What's the implication of non-routine? Well, it's not particularly automatable. So we've got a problem. This massive ageing population, no ability to really drive great automation efficiency as to how that ageing population is served. So it's just going to require more people. So making that workforce more efficient or more successful is absolutely vital, not only to our own health and well-being as patients, but to citizens, taxpayers. There is a small part here which is routine, but it's routine cognitive. It's not exactly routine manual, so it's a real issue. So that's a kind of the framework of why this industry is so important in terms of workforce success. So adoption barriers in health, what are they? Healthcare is very unique, I think, in this adoption problem. One reason is that adoption is institutionalised as a problem. And what I mean by institutionalised is, obviously for new clinical innovations, they require enormous regulatory hurdles to get to market. Now, that's not necessarily a bad thing. I mean, obviously it's good that drugs we ingest or devices that we use have gone through thorough testing. And the doctors and clinicians are obviously right to rely on regulatory agencies, to a large extent, to determine what is safe to use on us. The Australian equivalent is the Therapeutic Goods Administration. Generally, when the FDA approves out of the US, the TGA in Australia will approve. But it means long lead times to innovation, and it means a culture within the workforce of lack of trust for new innovation. And obviously technology, the way we think of it, is core to that innovation. So to get over that, what the government's done is set up a medical research future fund. You might have heard about this in recent federal budgets, to try and overcome this problem. Because what the problem amounts to is the requirement for very patient capital. The capital has to sit there and wait, often for 5 or 10 years, invest in very expensive clinical trials to get these approvals. And so you need long-term patient capital. And so the government has had to step in and say, right, well, how can we support the venture capital industry, in effect, to help support innovation in this country and ensure that Australia, which has a long and proud history of clinical innovation, doesn't fall behind other countries. So we've got government intervention in overcoming this institutionalised mistrust, I guess you'd call it. And there's this other problem with healthcare. Healthcare is almost what you call a public good. And the thing about public goods is they're around because of market failure. And I want to talk about market failure in the context of the My Health Record. You've probably all heard about that. Maybe some of you have signed out, opted out of the My Health Record. My view on the My Health Record is it's a circuit breaker for market failure. So essentially you've got this issue in healthcare where there's a lack of interoperability of systems. You've got GPs, specialists, dentists, allied health using their own systems, and they're very siloed systems, and the state hospitals, the private hospitals, very much the same. They have siloed, data stores that don't interoperate. They don't talk to each other. And left up to industry, nothing happened. Interoperability didn't come about. That's an example of market failure. And the reason it didn't come about, you could point the fingers in a lot of different directions. In my view, a lot of it is just pure commercial interest. Is it in the interest of someone who controls data to make that data fluid? Lower your barriers to exit. It's probably not in your interest. If you're a GP who's worked up, now again, this is a bit of a sceptical viewpoint, but if you're a doctor or a practice and you've built up this massive store of patient data that ensures that patient keeps coming back to you, why would you make that open? Why would you expose that to anyone else and potentially lose that patient? And so to circuit break that problem, the government has had to spend $2 billion and counting, $2.5 billion by now probably, to come up with this My Health Record, to get over this interoperability challenge. Now, the My Health Record as it stands is next to clinically useless after that $2.5 billion of spend. Hopefully that'll evolve and change, but I don't think its role is necessarily to be clinically useful. I think its role is just to introduce a circuit breaker to bring about this change that we all need. So all of this plays to this resistance to adoption in health, technology adoption in health. And I guess to bring this home, there's a really interesting article, which if any of you are interested in this topic, I highly suggest you read. It's in the New Yorker, and it's about electronic medical record, electronic health record adoption in the US. It's about why doctors hate their computers. And they're fundamental. There's a few quotes here, but fundamentally, it's about doctors thinking that, why am I spending 80 to 90% of my time on data entry? Why am I spending time looking at the computer and not looking at my patient? Why do I have to skip through all these windows and tick all these boxes? I should be synthesizing data and drawing conclusions from that data, not entering it. So it's this massive issue, and obviously it's being forced by a number of policies in the US around EHR adoption. But doctors are enormously resistant to it. Now, we could say that doctors have altruistic motives in mind. They want to spend more time with their patients, sure. Do they think data entry is maybe below them a bit? Maybe. Do they want to give up their IP so fluidly? Again, maybe that's a problem. I didn't say it, but that's an opinion of a few people. So it provides a really good context to some of the problems of healthcare workforces adopting technology. So I said before that I'd give some of my career background and sort of explain how we approach overcoming these adoption barriers. So many of you would be familiar with the classic adoption curve of technology. You get your innovators who are willing to try new things, the early adopters similarly, who wait for the innovators to give their feedback. And then you start getting the more progressive whole of the population saying, right, these guys are onto something, let's jump on board. And then the late majority and laggards obviously get dragged kicking and screaming to it, but eventually they come. So in order to drive this adoption curve, what I'd like to do is plot on top the energy required to drive that adoption. It's like an activation energy. The investment, the beating the streets, the talking at conferences, to get the word out, to drive this adoption, to get people to see the light, to break down those barriers. Now, in healthcare, as I just explained, it is a whole nother challenge to break through that. And healthcare technology as a Silicon Valley investment case is a road just paved with failure. Failure after failure after failure. Health tech is a disaster zone from a venture capital perspective because of this problem, based on all those reasons I was talking about before. So, sounds like a problem for a chemical engineer. So, this is actually a stock photo. None of this is me or my friends, but I did look like this back in the late 90s, boiler hat, hard hat, boiler suit. Working on, heat exchangers and I can't even remember what it was now, it was so long ago. I remember there was a lot of beer at university, that was the good part. But what does a hard hat and boiler suits have to do with fintech, which is the solution that Surgical Partners, which I'll explain more about in a second, is trying to bring to market and overcome the adoption barriers for? So what's it got to do with it? Well, I've actually reflected on this quite a lot lately. What we've got here on the left is a flow diagram of a chemical plant. So you've got feedstock, source chemicals, feeding out of tanks. They might be controlled by valves or similar control mechanisms. There might be some kind of heat exchanger or mass exchanger, which regulates the temperature or evaporates certain chemicals. Then you'll have some kind of reactor vessel where those chemicals are reacted together to produce a new chemical that's presumably useful and of more value than the feed ones. So you've got valves, you've got exchangers, you've got tanks where the feedstock starts and where the product ends up. And here on the left I've got a sort of a map, an architecture and an event-driven transaction environment. So you've got source transactions, maybe coming from a database, going through a queue, which is a bit like a valve, going into a processor, an executor, which is much like a reactor. You might go through an API or something, which is much like a heat exchanger or mass exchanger. And then that ends up in a database, a bit like a tank. So the challenges around processing chemicals through a plant, are very similar to managing event-driven processing of data. To take this a step further, data is the new oil. I'm sure you've heard that expression. Well, this is the chemical makeup of petroleum, hydrocarbon, and this is a JSON object. It's actually an invoice. It's a transaction event that we process through our platform. A little bit different, but fundamentally, these are the things that are flowing through the pipes. There's a lot of similarity between engineering and data processing in a technology sense. So let's come back to this activation energy. So in chemical engineering, you've got the reactants, the feedstock. In order for them to react, you have to overcome this activation energy in order to get to the product. Now that actually might release some energy, which is kind of interesting. Might have some outcoming heat you could use in a heat exchanger or anything. But of course the problem, much like investment in overcoming technology barriers, the investment in generating enough energy to overcome this hurdle to reaction is a massive investment problem in chemical engineering. So, of course, the way you get around it is to add a catalyst. If you add a catalyst to this reaction system, you reduce the amount of energy that's required in order to catalyse or get that reaction going with less energy. So I'd like to talk more about adding catalysts and how we at Surgical Partners have used catalysts to overcome the technology adoption barriers we see. I thought it would also be useful to talk about the required environment. So much like a reactor needs an environment, overcoming adoption in a population requires an environment, and I would say the key ingredient to such an environment is timing. There's a lot of talk in the startup world in Silicon Valley about the number one ingredient to success of a startup is timing. So what's timing in this case? Well, reaching critical mass in order to introduce a product at an inflection point is a function of enabling technologies. So enabling technologies, might be the advent of cloud computing. It might be the advent of, in our case, integratable ledgers. Economic impetus, so what do we mean by that? Well, drivers that force the customers to adopt a technology. Now, economic impetus in the healthcare sense might be frozen Medicare rebates, which has happened for most of the last decade. It might be Medicare fee reviews which are going on. Specialists are getting all their fees reviewed. It's inevitable that the prices of certain specialist items will come down. Now, the last one's cultural buy-in. So is there an inflection point of willingness to adopt culturally? And I would argue in the healthcare sense, it's coming from junior doctors or digitally native, just like any industry, coming through and expecting stuff to be on their phone. Coming from a whole different cultural background. So obviously the timing, the conditions have to be right in order to make it worthwhile to add the catalyst. The catalysts are expensive. You don't want to throw the catalyst in at the wrong time. You just won't get the response. So what has been our experience with catalysts? So before I get into that, probably worthwhile explaining, who we are and what we do. So the way we address the problem is, the problem we're addressing, another way to put it, is outpatient healthcare services. So in Australia and New Zealand, this is a $60 billion value chain. So we're talking about 3% of the economy. So I wanted to give you a bit of insight into how that 3% of the economy is currently structured. You've got 25,000 GP specialist dental practices. And typically what they do is they run all of their data through a source system called a practice management system. Some of you might be familiar. There is increasingly integrated payments solutions like Tyro, Medicare Online. There's a number of banks that are bringing integrated payment solutions to the healthcare space, and they settle into bank accounts, those payment systems. Typically with most integrated ledgers these days, Xero, QuickBooks, MYOB, they've got bank feeds. So those settlements from Tyro, Medicare, are settling effectively into the bank feed and these ledgers. But what's happening in the vast majority of the industry is reports are taken out of the PMS to say, right, this is the money we've billed and collected, And that has to be chopped up. Typically, the practice retains a percentage and the rest goes to the doctors for their share of the billings. And typically that's done into spreadsheets. The spreadsheet will be chopped up into each doctor's share. That'll generate a PDF. The PDF will go to the doctor. The doctor will give that PDF to their accountant. Their accountant will enter that in the system. One of the key problems here is that when this report's extracted and manually chopped up with all kinds of errors you can imagine, the receipts that are in this source system aren't brought in to reconcile against these bank feeds from the payment solutions. They're not reconciled. And because there's no reconciliation of those payment sources, you get enormous fraud. There's no check and balance around what is recorded as being collected. And, you know, unfortunately, doctors are fraudulent. But rather than focus on that, I mean, what we're trying to address here, the problem we're trying to address is fraud within the practice. So practice managers and administrators squirreling away money. It's an enormous problem. Besides all the waste and all the human handling which goes on down this side, we think it's about $2 billion worth of waste. So remember that this $60 billion, most of it's funded by us. And that funding that we're putting in as taxpayers is going down the tubes. That's what's happening. So independent of any clinical innovation, there's just enormous opportunity to address this waste. So how do we do it? Well, we're extracting the data in real time out of the PMS. We're presenting it inside the ledger to reconcile this cash collection cycle. We're automating the doctor share of income into an app, which even integrates into their personal ledger to take the friction out of their personal financial affairs. We're accounting for the fee that goes to the practice. We're even working on instructing a payment from the practice ledger via the Xero API to the doctors. So taking all the friction out of that back end. So it's kind of accounting and it's kind of boring, but it's a big problem. And I'd just like to talk about some of the catalysts, coming back to getting over workforce technology adoption. How have we got around some of those adoption problems? Well, we've turned to influencers. Who influences the choice of a practice, often owned by a doctor, to adopt technology? I mean, obviously you've got to get the practice owners on board. There has to be some kind of incentive for them to do it. Well, one incentive might be you make things more efficient. But no great company is being built by cutting costs. It's not a great argument for adoption. So it's something, it's nice, efficiency is important, cutting out fraud is important, but it's not enough. So what can we do for the accountants? So the accountants, who are accounting for these practices, how can they win from it? Well, instead of getting a spreadsheet from all these GPs, specialists and accountants, how about you get a stream of compliant, consistent data straight in your ledger that you look at, regardless of source. So that's an enormous efficiency and pain saver for the accountants in the industry and bookkeepers. I'll get back to the doctors in a second. The practice management systems, you think, well, practice management systems, why don't they do the accounting integration themselves? Well, good question. I mean, in my view, from pure experience, it's just too damn hard. And that's why there's an opportunity for us to do it, amongst other reasons. But it's clearly in their interest. The practice management systems have been, got inquiries from all their customers, can you please integrate us to Xero? Can you please integrate us to MYOB? So there's clearly demand. So we're filling a demand point for them. So if we satisfy them and the accountants will talk to their clients and say, use surgical partners, right? So this is how using, influencers to overcome this adoption. Accounting systems, same thing. Xero will talk to you about frictionless business. You'll see it all through their material. But there is no frictionless in healthcare without us. Doesn't exist. So it's in the accounting system's interest to promote a technology like ours. Dashboard Analytics Solutions, got a representative of one such analytics solution in the room here. Clearly we, by calculating the doctor share and practice share and automating that calculation, which can often be quite complex, we're providing added insight to the dashboard solutions that are out there trying to sell to the practice owners. So again, they'll hopefully sell us. And payments is a really important one. So the more integrated the payment, the more reconciled the cash collection cycle. It's fairly boring subject matter, but there's heaps of new payment solutions, mainly the banks, coming to market trying to sell their payment solutions to the practices. Now, if those payment solutions aren't easy to reconcile at the back end, well, they're going to be dead in the water. And we've seen that time and time again. So work with the banks and the payment solutions when they're coming to market to say, look guys, when you sell your payment solution, you might want to talk about surgical partners because it makes it easier to reconcile your payment out the other side. So incentives to influencers. The other catalyst that we've engaged is defining standards. Because this is just a mess. It is such a mess. We've had to define the standard by which it's going to frictionlessly run. So there's already an accounting standard where, as I was explaining before, the doctor gets a share of the data that we extract from the practice management source of truth. The doctor gets a share, the practice gets the share. That's like a standard in medical practice accounting that already exists, where we're just providing an automation pathway for that to happen. So we're implementing that standard, but what we are definitely doing is defining a standard for healthcare payments integration. So you would think when a new payments provider like a bank comes to market and they integrate remittances into the source of truth, like Tyro integrating to a Vend or something, and they settle in the bank account, which is the left side of this BankRec screen and Xero for those that are familiar. When they remit into the source and settle into the bank, you'd think they'd think about keeping those two things consistent. By consistent, obviously the amounts and the dates are largely consistent, but what about the references? How can you make this easy to reconcile for the user, make a remittance reference and a settlement reference consistent, such that you get a reconciled outcome? You'd think they'd think of that, but they don't. So we spend a lot of our time going to these payments providers to help them follow a standard by which this is actually frictionless and reconcilable. So overcoming the adoption is in part by providing a means for which influencers can promote your product as highly complementary to theirs. The third catalyst, we'd love to think of doctors as altruistic. But how would that explain doctors being the biggest users of negative gearing and residential property? So, like anyone else, you've got to show them the money. Show me the money. So, when we've developed our solutions, it's been about exactly that, showing the money. So I've got an example here, which will show you. So this is our doctor app. We can white label it for a practice group. This is Oka Health, which I also believe is a Tanda client. So what we're showing here is, we show them lots of things, and this app can, integrate into their personal Xero file of the contracted doctor that works at a practice group like Oka Health. And we can show them their billings per patient over the last 14 days, say. And this is my billings, as in the doctor looking at the app. And this is all the other doctors working in the practice. Gamify it, Make it competitive. So we talk about cultural change and willingness to adopt. Obviously playing to the hands of the millennial doctors coming through, giving them technology tools that they want, and that also inform them about, their money making, will help reduce that adoption. So, show me the money. It's working for us. So, what's the moral of this story? So, let me end with Simon Sinek. I'm going to end with why. Well, the why for me personally is I love it. I just love it. Healthcare for me is just this playground of opportunity. I just love it. I love using my engineering background. I love using my financial literacy that I gained as a banker. But, I didn't particularly want to work in a petroleum plant and pump out climate change. I didn't want to work in an investment bank and disintegrate into soullessness. So, being able to use those skills and bring about this desperately needed technology change in health is something I see as a real calling, and the why for me is I love it. But just for another stock photo, it's really about the patients. I see this stock photo all the time on medical websites. To bring it back to that New Yorker article, which again I suggest you all read, one of the most fascinating conclusions from it all, they were just talking about, New Yorker articles, they go for like 20 pages, and it's, as I said, there's all kind of quotes from doctors and nurses bitching about using computers. And there was a doctor who was driving the EHR implementation project at one of the major hospital systems over there in the US. And as a doctor doing it, he was obviously going against the grain of his colleagues, and so he wasn't a particularly popular guy. But he was interviewed by the article, and what he said was, the default assumption is this is a system for the clinical staff, but it's not. It's for the patients. And there's a really interesting bit of context here. So while 60,000 staff members use the system in the hospital, more than 10 times as many patients log into it to get their lab results, remind themselves of their medications they're supposed to take, read the office notes. This is a value to the patients, right? Which is meant to be what it's all about. So hence the My Health Record, and hence its need to sort of kind of circuit break this lack of adoption of interoperability between systems. So thanks for indulging.